Welcome, everyone, to WeNAP, which is Webster Nurse Anesthesia podcast. My name is Michael Burns. I'm an assistant professor at Webster University in St. Louis, Missouri. I've been a CRNA for 22 years, and my plan is to have monthly and progressing to weekly podcasts on various nurse anesthesia topics. The target audience are my SRNA students at Webster University or other universities, basically in preparation for their clinical days as well as their board exam. CRNAs that are wanting to just review various topics for their clinical practice and reboarding, and also RNs, especially those working in the anesthesia-related units, or those interested in possibly attending or applying for CRNA schools. Respiratory therapists, paramedics, everyone's welcome. Physicians, anyone that's interested in the topics presented, please share with, if you like them, share them with other colleagues, and hopefully we can get some very interesting discussions and facilitate some learning. I also recommend that when you listen to the podcast, it would be best during some exercise. If that's not possible, maybe during your daily commute, better use of our time as we're driving, and hopefully get something useful out of this. So let's get started. Our first topic is probably the most important topic of anesthesia, which is airway management. And I chose that one first because it's clearly a very important aspect of anesthesia care. All right, so the 3 A's of anesthesia we'll go over first: airway assessment, airway plan, and then the updated ASA 2022 difficult airway algorithm and some management strategies to help you in your practice. The 3 A's of anesthesia: airway, airway, airway. Basically, it is you cannot do the anxiolysis, the amnesia, or analgesia without proper airway management. And it seems to be all the unwanted complications related to anesthesia. A large majority of them have a big relationship with airway and possibly airway mismanagement. So airway assessment. Before all anesthetics, even monitored anesthesia care, every time regional anesthesia, you must do a very complete airway assessment. And I really want to emphasize the idea of monitored anesthesia care. It does not mean minimal anesthesia care. It's actually, in my opinion, maximum airway concern because you're not securing the airway, and you're definitely putting the airway at jeopardy with sedation, maybe different positions in the procedural rooms or operating room. So maximum airway concern is kind of what I think MAC anesthesia really is. If you fear the airway, maybe MAC anesthesia is not a good option, because even with the best of vigilance, you're going to possibly lose the airway and not be completely the best prepared for it, which, without pre-oxygenation, that's, significant enough to prolong the effects of or resulting in hypoxia. So airway assessment. So you have some basic questions you have to answer yourself when you do your assessment. And they're really basically 5 basic questions. And if you look through all the literature, it seems like it's over and over. Everyone comes up with these same 5 questions. Is, will you be able to mass ventilate this patient? Because remember, we call it an induction of anesthesia, but it's really an elective termination of spontaneous ventilation. And so before you do that, you have to make sure that if you can't intubate them, will you at least be able to mass ventilate them? And so that's an important question. Will you be able to mass ventilate this patient? Number 2 was, will you be able to intubate this patient? The third question you ask yourself: what is the aspiration risk? They have a full stomach, their food ingestion, fluids, blood, who knows what. That's a big assessment risk to do. Number 4, how difficult will the placement of an anterior access to the neck airway? And so as you go through the algorithms we'll go over later, you want to ask yourself, this parachute, is it really going to, how difficult will it be to engage this parachute? Doing front access neck airway is pretty difficult, especially in someone that has a large BMI, thick neck, or some sort of pathology there. And the 5th question will be, how will you extubate this patient? And so I always end with, if you fear the airway, should you secure it awake? This is absolutely every time you start assessing people and you start answering, I'm not sure if I could mass ventilate them. I'm not sure I could intubate them. And front access of the neck airways can be extremely difficult. This is no place for elective termination of spontaneous ventilation. Maybe secure the airway awake. It's definitely not a place for deep monitored anesthesia care, or maybe even monitored anesthesia care, period, without some other major considerations. So airway assessment starts off with the basic stuff. Review the medical history. What pertinent medical histories related to the airway? They have cancers of the neck and oral cavity. Have they had radiation, multiple surgeries, anatomical distortion related to either trauma or congenital related defects? Also review their previous anesthesia record. We use the Epic electronic record at our facility. The care everywhere is fantastic to be able to look at anesthesia records that were done previously, either eventfully or uneventfully. And if you look at those records and they happen to have a little bit of age to them, please check and see how long ago it was. Has that person's physiology changed since then? And look at their weight. I'm a big fan of looking at, how many kilograms were they at that either difficult or easy intubation, and see how that will transfer to your anesthetic management today. So Dr. Binyamov, certainly I consider him one of the major gurus of airway management and anesthesiology. I have a ton of respect for the guy. I think he came out with this updated presentation of 11-step assessment in anesthesiology, and certainly one of the leading physicians in relation to airway management. So basically he has 4 major categories of the examination. It's dental, pharynx, mandibular space, and the neck exam. And as it kind of guides you through kind of the entrance into the airway and to actual placement of the endotracheal tube. And so a dental exam should look at the size of the central incisors. They're very large. It's going to get in the way of your direct laryngoscopy blade. Do they have a major overbite? Pretty sensitive test would be an upper lip bite test. And you also want to look for a mouth opening, and you hope for about 6 centimeters. The pharyngeal exam is the Mallampati. With special care to note the size of the tongue in relation to the oral pharynx. And so if you have a really large tongue and a really small mouth, a disproportionate, it's going to get pretty crowded in there. And so that's going to not give you enough room for a proper view and or placement of the endotracheal tube. Assess for an arch palate. Again, can get pretty crowded back there as it narrows that space for us. Mandibular space exam. This space that you will anteriorly displace the tongue. And when you think about a direct laryngoscopy, as we're pulling up, we're displacing the tongue anteriorly into this space. And if it's, let's say they've had radiation, they've had a tumor there or hematoma, any sort of pathology forming there, that thyromental space is not going to allow us to anteriorly displace the tongue. We're hoping for a thyromental distance around 6 centimeters. Compliance of this space, we must assess to see if it's soft, check for pathology or firmness. So again, that mandibular space is where we're going to anteriorly displace the tongue when we do a direct laryngoscopy. And any pathology there obstructing that displacement is going to minimize our view and maximize our difficulty with direct laryngoscopy and ultimately intubation. What about the neck exam? We should look at the neck length, the neck circumference. Certainly we'll talk in a little bit about some studies that demonstrate that neck circumference is in fact associated with difficult airway management and intubations. And range of motion, check for that to see exactly what type of movement can they do. So back to our first question. Will you be able to mass ventilate this patient? It's a very important question. The risk for difficult mass ventilation, as several studies agree with this, if the patients have obstructive sleep apnea, obesity, a large neck circumference, BMI. BMI is kind of a double whammy there as far as difficulty mass ventilating, but also they're likely to have, or they're going to have a reduced FRC. And basically you're going to run out of time before they start decreasing their saturations and hypoxia starts occurring. If they have a beard, edentulous, elderly, and radiation to the neck. And so these are kind of things to check for that's going to kind of stack up your risk assessment if you have a difficult time with mask ventilation. So the other question is, will you be able to intubate the patient? Will they aspirate? And how long will the placement of a surgical or an anterior access to the neck airway take? So again, time is against this, especially folks with decreased FRCs. And we know that those oxygen saturation will start going down pretty quickly. If every step is going to take longer, maybe we should consider securing that airway while the person is awake. And an important question that has to be answered with the initial airway assessment and before you spontaneously or before you terminate spontaneous ventilation is, how will we extubate this patient? And we'll get to that. We'll talk about that in detail. But again, you have to give that big thought is, will you extubate in the operating room? Will you extubate over exchange tubing? Will you plan to have them ventilated in intensive care overnight or for a prolonged period of time? How will you communicate to everyone that this is an important extubation, that it was difficult possibly to place, and we should notify people, maybe kind of like schedule a time and a place for this extubation to occur. So about the idea of, just to kind of make sure our terms are universal, difficult laryngoscopy is difficulty viewing the airway anatomy, and that's related to the Cormack and Lehan scores. You can see them on the screen. Most people are familiar with these as far as, grade 1 view. Grade 2 gets a little bit, there's some, 2A and 2B. Do you see just partial view of the glottis versus 2B? You just see the retinoids or just the posterior part of the vocal cords are only visible. A 3 grade view is basically only the epiglottis is visualized, and grade 4 was neither the glottis nor the epiglottis is visible. And so again, grade 1 is, it's perfect. You can see everything, full glottis in view. And once you leave grade 2 view, it's going to be pretty difficult. You have to do some maneuvers to either improve your view or certainly use some adjuncts to help facilitate intubation. So difficult tracheal intubation, and this is key, that it requires more than 3 attempts or non-standard equipment. So, you finally do get the intubation and it's like, well, I don't know if it was really difficult. You ask yourself, did you have to use a non-standard equipment? Then if you did, then it's considered a difficult tracheal intubation. If you had more than 3 attempts, and you have to communicate that on the electronic medical record or the anesthesia record for future anesthetic managements and the safety of this patient. I mean, above all, do no harm. And we're absolutely interested in the safety of our patients. And so we thankfully got through that event. You want to make sure that you appropriately communicate that they did in fact have a difficult intubation for, and what allowed you to be successful. Please communicate that to your on your record where others can benefit from that knowledge. All right, let's look at some evidence, because we do these bedside assessments. We all the stuff to do, the 11 steps, but then you kind of wonder, like, which ones are more important than others? Is there like a grading score? It'd be nice if you had like a score of 6 or more. That means an awake intubation. We don't quite have that yet. To the best of my knowledge, it's still out. Still out to the literature to help us with that. One of the tests that is pretty sensitive, though, is the upper lip bite test. It has really good sensitivity and specificity, and we like to think that if they can really do an upper lip bite test, that really helps us with that mobility, that we can anterior displace the mandible or move the mandible anteriorly and give some extra room with direct laryngoscopy. Another sensitive test is neck circumference. It's 92% sensitive, and if it's combined with the Mallampati, it gains specificity up to 92%. And Riyadh and others looked at this in 2016, and you'll see this sprinkling throughout the literature, that both neck circumference and upper lip bite tests seem to be pretty useful bedside tests to predict if someone would have a difficult airway or difficult tracheal intubation. Some more evidence, BMI and obesity. Boy, it's really plus and minus some of the studies with that. There's a higher correlation with males and advancing Mallampati scores, difficult mask ventilation, especially with a history of obstructive sleep apnea. But then, you look at some studies and show that, folks that were morbidly obese were intubated just fine without any increased incidence of difficult tracheal intubation. But if you look at the methodology in those studies, you'll find that they were really good with positioning. They were in the sniffing position, ramped up on some pillows and blankets. That's the key. Is I think maybe some of the studies are not quite as universal. BMI leads to difficult intubation. I think it's because of how well they were positioned. So what's the moral of that story? Is before you electively terminate spontaneous ventilation, make sure they're properly positioned, and really take care to do that, because you want your first direct laryngoscopy to be your absolute best shot. It's not like, well, I'll improve it if I have difficulty. They have a large BMI. You have things stacked up that you will absolutely put yourself at a higher incidence of difficult intubation or difficult mask ventilation scenario. So optimize, put your best foot forward. So one of the studies looked at a BMI greater than 50 and a neck circumference greater than 42. They were predicted of difficult intubation. All right, so back more about neck circumference. And you think, oh, God, who really measures people's necks? We do. I work in our pre-anesthesia testing clinic every Wednesday, and been part of that clinic for a long time. And we instituted measuring every patient that comes to the PAT clinic, measuring their neck. And OB patients especially, anyone that comes to the PAT clinic gets their neck measurement first. Not first, but part of their visit. So neck circumference of 40 centimeters paired with an elevated Mallampati, so like a 3 or a 4, had a 5% probability of a difficult intubation. Now, if your neck circumference is 60 centimeters, which is a very significant neck circumference, they had an increase up to 35% difficult intubation. So that's pretty significant. I mean, when you walk into see someone in the pre-anesthesia area and you have a very large neck circumference, 35% chance of having a difficult intubation, boy, you can be really tempted to just do an awake fiber optic intubation on them, unless you have some other information that's going to be very reassuring that you could either mass ventilate them or, in fact, intubate them. So the odds increase 1.13 times for every 1 centimeter increase in neck circumference. Again, this is a study back in 2002, Burns and others. I think it's pretty good to kind of put some math to this, that your odds increase of 1.13 for every 1 centimeter increase in neck circumference. So again, you can see it with the 40 centimeter compared to the 60 centimeter neck circumference. You're truly increasing the chances of having a difficult tracheal intubation. What about some more assessment tools? You've heard of the Lemon score. This is great where you look externally, you evaluate the patient. Is the mandible 3 fingers in length? What's the distance from the hyoid to the thyroid? 2 fingers. And they also, can the patient fit 3 fingers between their central incisors? See if you can have some room in there. And then they also look at the classical Mallampati score. The O is for obstruction or obesity. And so again, any kind of conditions that, epiglottitis or head and neck cancers, Ludwig's angina, where I work full time, we do have some of those sprinkle through here and there as far as, really bad dental abscesses and so forth. They have a hematoma, something that's going to obstruct your airway, or do they have, morbidly obese as well? Neck mobility is the end. Neck extension is the most important maneuver, and it's a simple extension. Can they do the sniffing position? When you think about sniffing position, I really want to, I know some of you are CRNAs, as the SRNAs and folks that are maybe beginning their anesthesia education process. Sniffing really isn't looking straight up to the sky. It's like kind of picture like you're kind of sniffing a flower. You kind of push your nose forward and see if you're going anteriorly to smell for a flower. And that's the proper position that we're looking for. All right, some more assessment tools. I found one on this airmethods.com, heaven criteria. That was pretty good. It's like, because when they're coming into the emergency department, you're kind of, they don't really have a lot of opportunity to optimize that scenario. It's more a risk assessment and really try to optimize as much as they can. But their criteria for heaven was if they had hypoxemia, so if their saturations were less than 93% at the initial laryngoscopy, extreme in sizes, pediatric or clinically obese. If they had an anatomical challenge, trauma, mass, foreign body, some sort of structural problem that's going to limit their laryngoscopy view. The V was vomiting and blood. If it's present in the pharynx or hypopharynx at the time of laryngoscopy, and exsanguination, suspected anemia, potentially accelerating desaturations during the RSI. And then also the neck. Was there limited cervical range of motion due to immobilization or arthritic changes? This kind of scale that I really was hopeful to see more of is openairway.org. The airway assessment is, if you're in the red zone, your thyromental distance is less than 6 centimeters, mouth openings less than 3, and your neck extensions less than 10 degrees. And it's really nice. Your upper lip bite test is grade 3. They can't do it. And so that's really kind of stacking up the red zone that maybe you should think about. That's an indication for an awake fiber optic intubation. And so the kind of the gray zone or yellow zone in here is where you're in between. Your thyromental distance is okay. Your neck range of motion is okay. But your upper lip bite test is, a grade 3. So video laryngoscopy. And I would say if you're in the yellow zone, what's going to make some prediction for me anyways, is do I think I can mass ventilate them? If I'm in the yellow for my assessment with tracheal intubation, then I'm going to bring in some, what's the likelihood of me having trouble with mass ventilation? If that happens to be yellow or even brush up to the red zone, we're going to have to probably secure that airway awake versus, again, electively terminating spontaneous ventilation. It's nice in the green zone, just proceed with direct laryngoscopy. Certainly, good distance, good mouth opening, good neck extension, and upper lip bite test. So. All right, so back to our question. It kind of makes us like, boy, we did the airway assessment. It looks like it's going to be marginal with tracheal intubation. What about mass ventilation? And so there's some mnemonics out there as far as, again, openairway.org had one out there with M mask, is, are they male in gender? We have a problem with sealing the mask. They have a beard. Are they edentulous? Mallampati scores, are they advanced, 3 or 4? Mandibular protrusion. And so what about their age, snoring, obstructive sleep apnea? And what's their weight in kilograms? Another mnemonic is obese. Are they obese, bearded, edentulous, snoring, or elderly? And those are all risks that are known risks and associations with difficult mask ventilation. And I've had many patients, not as many as maybe I would like to have had, but I've had several, let's say, patients that I saw them in the PAT clinic, and I was a little concerned about the airway. They had a really big beard. And to my surprise, I've had, like I said, several of them either offer or shave their beardy for the morning of surgery. I mean, I've seen several of them show up, clean shaven. They're like, hey, you were mentioned about my airway. And I went in to make sure for you guys. And obviously that means they have complete buy-in. No one wants a bad complication or a bad outcome. And that's the best of all scenarios. So occasionally we'll see that. If you have time to discuss it, it's not a bad option. So as we think about our plan B, so with the difficult airway algorithm, if you can't intubate, can't ventilate, go to supraglottic airway placement. It's nice to Bella again says, well, how difficult will be my second option here? And again, one of the assessment tools is limited mouth opening or some sort of obstruction in the hypopharynx. It's not going to allow you to have air movement into the glottic opening and ultimately into the trachea and lungs. About lung compliance. So let's say they have severe obesity or some sort of coexisting restrictive lung disease, or even any kind of parenchymal lung disease that could make it difficult with lung compliance. We're going to have to generate a higher airway pressure, which could end up us ventilating the GI tract more than we are the pulmonary system. And again, predisposing us to, hypoxia, hypercapnia, but also aspiration, worsening already bad situation. What about cervical spine? Do they have a limited range of motion? They have airway trauma, and again, elevated BMI is up there as far as difficulties with supraglottic airway placement. This is a big one with difficulty with anterior access to the neck or front of the neck airway. If they have a trauma or tumors in the area, a hematoma, if they had prior radiation therapy or surgery, there's some scarring there, and again, neck circumference. And so when you guys start thinking about your airway assessments, hopefully you're already starting to okay, there's intubation I need to assess for, there's difficult mask ventilation assessed for, supraglottic airway ease management. And then also, if you're gonna have to do an emergency front of the neck airway, if that's your last plan, you should ask yourself how easy or difficult that's going to be. The reason you're doing this very thorough assessment for every anesthetic, because once you electively choose to or put them at risk for termination of spontaneous ventilation, you must be prepared to secure their airway. And if you are stacking up the risk that all areas are going to be difficult, then the option is an awake fiber optic intubation. So anyways, it's just very repetitive, but it's a ongoing theme. It's all about safety. We have to think about not the plan that's just induce and place the endotracheal tube. We have to think, if that fails, what are we going to do next? If that fails, what's next? So what about ultrasound? This is the greatest tool, right? POCUS exams on the airway. The challenge is that every patient with their airway assessment, we should identify their cricothyroid membrane. And so if you notice, that's been missing from a lot of these tools that I talked about so far. And ultrasound is obviously a much easier tool to identify someone's cricothyroid membrane. And I would challenge that either do with ultrasound or palpation, you should find every single patient's, you should identify their cricothyroid membrane prior to electively terminating spontaneous ventilation. And that's a great challenge. And if you're gonna, when we go back and do awake fiber optic intubations and we're prepping the airway with topical local anesthetics and, like dexmedetomidine for sedation, it's pretty big moment when we actually identify the cricothyroid membrane and we put a mark there. I think the patient knows exactly that's our plan, and they have immediate buy-in as far as having the topical anesthetics truly sit there at the back of their hypopharynx and really anesthetize their nerves. While it could provoke a lot of anxiety, it's also it's very good to do that to make sure you can in fact have that backup plan if absolutely necessary. You can look at the distance from the skin to the airway structures. You can also look at the vocal cord anatomy with an airway exam via ultrasound. Difficult airway incidents, elective situations. So in anesthesia, elective surgeries and so forth, we're talking about 1 to 2,000. Obstetrics, on the other hand, is now with those rapid sequence inductions, we're looking at about 1 to 300. In our emergency department intensive care environment, it's about 1 in 50 to 1 to 100. And so, the last 2 years, I would say with all the COVID related influx of patients and volume, our facility that I work at, I have personally have done more outside the operating room than ever before. And we spend quite a bit of time in the emergency department and intensive care. And truly, those difficult airways are much more common because, again, it's not planned, it's not elective. They're in extreme respiratory distress, and that sometimes optimization is not always available, or do you have time for that? So be very vigilant. You want your absolute best foot forward when you enter the emergency department and intensive cares. We have glide scopes in all of our operating rooms for video laryngoscopy. We have our ED, as well as our intensive care and obstetrical environment, to truly make sure the entire tool set is available for its difficult airway algorithm. But our first and initial intubation is with video laryngoscopy in that environment. So direct airway management. The best thing is to prevent with good airway assessment, right? To prevent a bad situation is to prevent getting yourself in it. Proper positioning and ramping. This is where you got to watch out for production pressure and all the excitement in the operating room, and everyone's egos are at risk. This is a time to leave your pride at home, just take care of the patient, be as safe as possible. Make sure you anesthetize every patient as if that's like a close family member of yours, and that you want absolutely no exception, but only the best for them. Another preparation thing is to have airway cart. The ASA difficult airway algorithm just updated in 2022. They give a nice list of everything you should have for every anesthetizing location, which means every time you do an anesthetic, and then also the components to the difficult airway cart that should be immediately available during the administration of anesthesia. And another part of that is do drills. We have annual skills day in our department where we do an afternoon. People come in for, pizza, whatever. It's nice to have some professional camaraderie with everyone, see people outside of, the usual work hours. And we have like a cricothyrotomy station, weight fiber optic station, massive transfusion station, stuff like that. The point is practice these things. And the drills are super important because you need all the staff to participate, surgeons, circulators, everyone that's involved. So we highly encourage doing some airway drills as far as difficult airway management. What about the evidence with airway risk assessments? This is the part where you're like, all right, you spend all this time, all these assessment tools, but they really help. Unfortunately, there's some literature that demonstrates that they really didn't help that much. Even though we knew that this person could be a difficult intubation, the prediction is a little bit weak with that. So again, it does lack some evidence. There's no difference in unanticipated difficult intubations as well as anticipated. So unfortunately, these tools don't seem to really bear a lot of fruit yet with that. So what about airway management items for every anesthetizing location? And this is, right out of the 2022 difficult airway algorithm from anesthesiology. Self-inflating resuscitation bags should be available. Suction tubing, catheters, connections, mask of various sizes, various types of and sizes of oral and nasal airways, different sizes and types of blades and handles, endotracheal tubes, stylets, some that are malleable, some that are rigid. And the stylets, if you have video laryngoscopy, you have to have the stylet that's used with that set. Should have invasive airway equipment, supraglottic airways, multiple sizes for this patient. So back to supraglottic airways, when you're anesthetizing, let's say someone like a pediatric patient or an adult, a very large adult, you should have supraglottic airways, just like you do endotracheal tubes, that's for that patient population, that size person. And one above it and one below it to make sure you're set to go. Lubricant for replacement of supraglottic airways, and even some of our endotracheal tubes as far as anything having difficulty. Nasal cannulas, mask, oxygen masks. We talked about video laryngoscopy and necessary stylets. It goes without saying you should have the ASA standard monitors on prior to the electively terminating spontaneous ventilation. And you should have all planned and unplanned medications ready to go. Do you have rescue meds ready? All of that should be in the room at every single anesthetizing location. About your difficult airway cart. So now we're talking about the cart that's being set up. And again, the Anesthesiology 2022 difficult airway algorithm article spells out exactly what to put in there, right? You need alternative rescue ventilation and intubation equipment. Some duplication plus some other devices. So if you have, a lighted wand or whatever you like to use, your department has that. Maybe they'll have one or two of them or three of them. That's the kind of stuff you want to put in your difficult airway cart. Equipment for an awake fiber optic intubation. Now, our difficult airway cart has all the little extra toys in there as far as assistive devices, but is the complete setup for an awake fiber optic intubation. Now, the idea is if it's a planned awake fiber optic intubation, you wouldn't use those items in the cart. You would have them prepared, but that cart is always ready to go with a little lock on it saying it's been stocked and ready to go. Tube exchangers, invasive airway equipment. And that's the emergency front access to the airway. The jet ventilator, CO2 detectors. Make sure you have a few of those just in case, one falls or whatever. Laminated cognitive aids. This is a big one. We have, the crisis checklist in the operating rooms. You have to have these checklists. You have to have these difficult airway algorithms. And the most updated version, just print it out, laminate it, and secure it to your difficult airway cart and put it in the operating rooms. Each of your anesthetizing locations should have these cognitive aids. I think they're very helpful. Okay, so speaking of the ASA algorithm 2022, kind of what's the part that to think about some of the changes is, again, plan for an awake fiber optic intubation if one or more are present. And that's a high risk for difficult mask or supraglottic airway ventilation. So that's why we kind of went over that risk assessment. Really think about aspiration risk. Does this person have a full stomach? Do they potentially have a full stomach? They have a history of, bleeding or something like that. Unable to tolerate apnea, even if it's brief. What if their coexisting disease or their situation is that they're not going to tolerate even the most brief moment of apnea without major decompensation and hypoxemia? And what if they have a predicted difficult with surgical or invasive rescue? And again, that's why we mentioned the assessments for that, where you can stack these up and say, this is going to be a difficult mask ventilation, difficult supraglottic airway management, and a difficult surgical or invasive rescue. We should do this awake fiber optic intubation. And I can tell you, you're not going to be the most popular guy in your department or probably in the perioperative period. I've had, over 22 years, I've had some pretty negative PR related to doing more awake fiber optic intubations. It's just, again, before you electively terminate someone's spontaneous ventilation, and you have all these useful tools that this assessment is telling you that you're very likely to have problems with every step of this plan. It's just really so much safer to do an awake fiber optic intubation, and certainly should be viewed with great care. I mean, that is quite the ordeal for the patient and even the the efficiency of the operating room, but safety first always. Another thing they alerted us to with the recent ASA guidelines is time, is that increase your awareness to time and condition. How fast are these patients decompensating, and should you move at a quicker pace to get to a more definitive securing of the airway? And limit the number of attempts and devices. Again, worsening a problem. The big, another big area of focus was extubation plan. And this should be pre-planned. And, again, we talked about when you assess the airway initially, you should make a plan for extubation. But let's say you finally get the intubated, unanticipated difficult airway, they're intubated. Now, what do? Make your extubation plan as you're doing the operation or the situation that you're in. One of the key things, patient readiness. Are they in fact ready for extubation? Is their condition stabilized where they can be extubated safely? And should you do so under an airway exchange type catheter? We use the Cook's catheter. I think they're pretty popular, pretty easy to obtain. Patients seem to tolerate pretty well, as long as the catheter is not hitting the carina. You have to be very careful of that. And we kind of just lay it off to the side of the mouth and put the mask over it, where it's and maybe limit some of their head movement where that exchange tube doesn't have inadvertently hit their carina or really move around too much in their hypopharynx. And they seem to tolerate it pretty well at that. And once they're, established that they're safe enough for extubation, they're fully awake, their oxygenation great, their carbon dioxide levels doing well, and it's excellent for monitoring end-tidal CO2. We plug that into our end-tidal CO2 monitoring. It's really been a great asset to our department. Appropriate time and place for extubation. I like to think of the idea like, okay, let's schedule an extubation. It's like, okay, we can wean the patient in the ICU. They're doing great. Let's go ahead and extubate now. I like to think of let's schedule the extubation. Let's find out when the anesthesia team's available and have someone at the bedside with the difficult airway cart with them, and really ultimately be fully prepared for a proper extubation. Again, like even over an airway exchange type catheter. Staff and equipment, mentioned that already, preparation for extubation, and oxygen therapy throughout this extubation process. So communication. So let's say you have a difficult airway. How do you communicate it? Accurately and completely document within your medical record. Certainly that's going to be reproducible for folks like myself. I work in a smaller town. If there's something happens in a larger city, a big environment, it's nice to see on their electronic medical record, I can read exactly what happened and help me manage their airway appropriately in our environment. National database. Certainly it'd be great to have all our difficult airway patients logged there. Patient card. So every difficult airway patient we have a separate form that we fill out that's scanned into the electronic medical record under difficult airway. We properly document in our electronic medical record. And we also give the patient a card, kind of like their pacemaker card. And it tells that they have a difficult airway, but real importantly on the backside, it also tells the patient or the next provider what was successful and what wasn't. And then if we're leaving them intubated, we put a sticker on the endotracheal tube. It's like fluorescent pink or green or yellow, and it says difficult intubation. And that alerts, let's say we were sending them to another hospital for transfer or up to the intensive care, but everyone that encounters that patient, they have a sticker on the endotracheal tube communicating that they're a difficult intubation. And I've seen places where they put the sticker outside the ICU window. All of that are great things. You can't over communicate this. And really, when we give the patient card to them, we make sure they're really good and awake, and make sure their family's present. And one of our members of our department goes and speaks to the patient and the family about their difficult airway situation, and notify them to present this card as you would like a pacemaker or something like that, coronary stent, their card with that, if they are having elective surgery, any kind of procedure with sedation or anesthesia. This is the difficult airway algorithm. And basically in red, they highlighted the things that have some of the changes. Optimize oxygenation throughout. That's probably one area. And you can see the box where they talked about limit the number of temps. And we put out, we already discussed that, but consider calling for help. And you really want a more experienced person and to use a different device, like video laryngoscopy. You want to upgrade with that, but you really want to limit the amount of attempts to minimize the airway trauma and ultimately making a bad situation worse. Limit the number of attempts and consider awakening the patient, especially if you're in a non-emergency department or ICU type scenario where you have to secure the airway. With elective type surgeries and elective anesthetics, this is an option, is limit the number of attempts don't make the situation worse, and see if you can awaken the patient. With rapid sequence inductions with succinylcholine or with rocuronium and sugammadex, you can kind of limit that number and really possibly get you out of a situation that of a horrible situation to make it better. Limit the number of attempts again, and beware of the passage of time. Call for help and call for invasive access. And that's the other area. Is the common theme here is oxygenate throughout, limit the number of attempts, and make the decision sooner versus later to do an invasive access for surgical type airway or awaken the patient. And if you're unable to awaken them and you're still unable to mass ventilate or intubate, supraglottic airways fails, you're going to have to go into the invasive access. This is a joke with some of my students. I've done this a few years ago. It's the preoperative airway assessments. My name, M. Burns. It's to look at medical history and conditions, airway history. They have radiation, cancer. And it's really, that's going to help you with difficult intubation, mass ventilation, and front access to the neck. BMI, if it's greater than 40. The U is for upper lip bite test. R is for routine Mallampati, 3 or greater. N is for neck circumference. And did you identify the cricothyroid membrane? And S is they snore or obstructive sleep apnea. And maybe the Mr. Burns on the Simpsons picture kind of reminds people of me. I always ask the question, certainly since the last, the POCUS exams and so forth, is did you identify the cricothyroid membrane prior to electively terminating spontaneous ventilation? I think that's an excellent addition to an airway assessment tool, and certainly hope folks start incorporating that into their practice. Okay, that's everything. I hope this is an enjoyable podcast. I apologize for any of my poor performance with the podcast. It's my first one. I hope that we'll have more to come soon, and I look forward to getting some feedback from you guys. And please send me an email or just notify me via the YouTube channel for questions or concerns. And again, I look forward to future podcasts, and I hope you have a great and safe day at work or practice. Take care.